My name is June Andrews. I'm 84. This is the story of my trip to hospital.
Well, I'm David Oliver. In my day job, I'm a consultant physician at the Royal Berkshire Hospital, and I spend my working life looking after often very acutely ill, frail older people from the front door of the hospital all the way through discharge and out into the community. And for the past year or so, I've been one of the members of the Health Service General Commission on the care of frail older people in hospital. So what we intend to do is run the film forward and stop at 4 or 5 key parts of the story. And the purpose of it is to get people focused on what could and should have happened differently in an ideal system.
It started one Friday evening when I had a fall in the bathroom. My husband called the out-of-hours doctor, who told us to call 999.
The events in the story, I'm afraid, are all too real, and I've played this to numerous audiences of experienced health professionals, and many of the things that happen really have resonance to them because we see these things happening in services. She's an old lady who's becoming frail, possibly becoming a bit demented, who falls over and ends up in the machine. Even though there are caring staff trying to do the right thing, she ends up being conveyed to hospital, admitted to a ward, where she becomes immobile quite quickly, and then she's moved several times and then discharged without a proper follow-up plan. A lot of what happens to her is completely avoidable if only we'd done the right thing at various stages of the care pathway. So, the first thing, if we watch the animation, you can see that Mrs. Andrews had suffered one previous fall. She's on at least 4 medications for blood pressure, which she may not needed to be on. Her memory was starting to go a little bit. She was possibly starting to develop some frailty, and frailty is where people don't have much in reserve. They've got slow walking speed, they've got muscle weakness. So in an ideal world, a lady like that would be on the radar. They'd be known about by the general practitioner and the community team. They'd have the medication properly reviewed and adjusted. And the other thing is, there's very good service models where with shared care protocols with the ambulance trust, you can avoid diverting people to hospital and actually put rapidly responsive service into their own home instead of conveying them, or divert them to a rapid chair-based assessment clinic the next day.
Mrs. Andrews was moved on to the acute medical unit. She was getting close to breaching the 4-hour target. It was also getting late, and the AMU was a safer place to assess her and get her back on her feet. We put up a drip and gave her some antibiotic tablets for the urine infection. On Saturday morning, she was seen by the on-call medical consultant. Before we could look at her mobility, the patient flow team insisted we move her to the first available medical bed.
So it's reasonable enough that Mrs. Andrews was moved from the emergency department to the acute medical unit for further assessment. However, what could and should have happened is she should have been in her day clothes, in her shoes, got out of bed the very following morning by the physiotherapists, and there should, in an ideal world, have been access to either what you call a discharge to assess team or an early supported discharge team to try and get her back to her own home. And in particular, we shouldn't medicalise people. If we put people in a gown, if we put them in a bed, we hook them up to a drip, we start giving them intravenous antibiotics, before you know where you are, they've become institutionalised. Whereas if she'd presented to a chair-based clinic, we would have treated her in a very different way. The other thing is that moving her off to a medical ward because of bed pressures is counterproductive. Having an acute frailty area for 1 or 2 days to assess people, turn them around and get them back home in the end is much better than just moving them to the first available bed, especially at a weekend.
The review team discovered that her blood pressure was dropping very low when she stood up, postural hypertension. It often leads to falls and faints in older people. We stopped a couple of her cardiac medications to try and solve this problem. By Wednesday, she was able to stand with assistance. The physios came to see her, and a plan was made to refer her for ongoing rehabilitation in the local community hospital before going home. But not for the first time. There were no community beds, and by the 10th day of June's admission, the cardiology ward desperately needed beds for acute cardiac patients, and she was moved to a winter escalation ward.
Well, first thing to say is escalation areas are generally bad news, and the CQC inspectors look at them first. They're often variably staffed and supported, and they're a symptom of hospitals that don't focus enough on patient flow and health economies that don't have enough capacity outside hospital. But the last person who should be moved to an escalation area is a frail old lady who's already getting confused and institutionalised. Every ward move puts 2 days on your length of stay. It worsens continuity, it unsettles the patient, and it increases the risk of confusion. And lo and behold, she arrives there, and because she's now disoriented and she spent all weekend in bed on the cardiology ward, she falls over And even something like a sprained wrist that she suffers can be the difference between you walking or not walking if you're frail and vulnerable. So everything that happens from that point on adds to her length of stay, and all completely avoidably if we'd actually got her out of the acute medical unit in the first couple of days with community support.
By day 12 of her admission, the community hospital phoned back saying that she had no rehab potential and should have a care package instead. She was referred to social services with a target discharge date for Friday, but the package couldn't be put in place till the following Tuesday. She went home with a 3 times a day care package, but with no clear diagnosis for her progressive memory impairment and falls.
The whole story illustrates the fact we don't have anything like a transportable shared patient record. The hospital staff spend a lot of time finding out what was going on at home. The GP may not even know that she's come into hospital or that she's coming home. So communication with community staff is absolutely vital. And she goes home, she doesn't have really a proper plan for assessing whether she has dementia or not, whether it's just mild cognitive impairment. She doesn't have a good, robust plan for preventing future falls. Her husband's clearly stressed and needs that support and information for carers. And she doesn't have reablement services that might help her improve her confidence, maintain her independence. When things do start to go wrong, she ends up in a nursing home, quite possibly avoidably if some of those things had been in place. No one's saying that she wouldn't end up in a nursing home eventually, but we could have delayed that. We've already talked about what's good for Mrs. Andrews and her husband, because this is ultimately about caring for people. But of course we are in a very pressurised emergency care system and a very cash constrained service at the moment. And so doing the right thing for her also has the potential to be good for the system and to release savings. And the kind of comparisons we have to make are the cost of conveyance to hospital in an ambulance, emergency department attendance, and then bed days in hospital wards, versus the comparable costs of home-based community rehab or reablement services, or in some cases community hospitals. And of course at the other end, when she ends up in a nursing home, that has a high weekly cost, and we must compare that cost, largely accruing to social care, versus the cost of alternative provision at home around reablement and maintaining her independence and low-key support for her husband. Many of the service models that could help Mrs. Andrews are already in existence in various parts of the system. It's just we're not doing it reliably for everybody in every health economy. One place people can find good practice studies is on our own website for the Commission, where we have 20 plus real life examples of good practice.